My name's Sarah Ostrowski. I'm a care coordinator in the Oxford area on the complex palliative care outreach team. And I'm here with Dr. Karen Fryer, Patti Harmer, who is a nurse from St. Elizabeth, Marlene Franklin, who's also a care coordinator, Suzanne Christo, who works for Care Partners, and Jane.Downey, who is one of our eShift managers. So we were asked to share a story of one of our patients that was helped out in the Oxford area by the palliative care outreach team. So there's our obligatory presenter disclosure form. None of us have any conflicts, I guess. So the learning objectives are just there. So we were asked to share and reflect on an outreach care story which illuminates the best possible palliative care journey through the end of life, and a discussion regarding facilitators and potential barriers to the patient having the best possible palliative care journey while on the outreach team. So we'll get to that a little bit later. So who are we? This is a little bit of a rundown of the people that are involved with the Oxford Elgin Palliative Care Outreach team, including a couple of our partners, so eShift and Secura House. So our story begins with Mrs. K. So there is a handout that we gave out to you that shares a little bit of her medication history and a little bit of other information about her, which I won't go through because you all have it. But Mrs. K is a 77-year-old woman who resides in Oxford County with her sister-in-law. She has a daughter and a son who live locally. She also has a sister and a niece and her mother-in-law who she identifies are sources of support for her. She quit smoking but has a greater than 50-year PAC history. She drinks occasionally, for example, when she goes out to pub night at her mother-in-law's nursing home. In the past month, Mrs. K has been seen in the ER twice with increased shortness of breath and diagnosed with exacerbations of COPD. She's currently identified with a diagnosis of end-stage COPD. So she was referred to the Southwest LHIN and the Oxford Elgin Palliative Care Outreach team by her primary care physician. Her primary care team discussed the referral with her and her family, and they completed a DNRC form with her at their office. Together, following an assessment with the Southwest LHIN intake care coordinator over the phone, her services on initial referral included nursing for pain and symptom management and an occupational therapist to assess for home safety equipment and to teach her strategies for energy conservation. She was connected with the complex team on her admission to LHIN services. So her referral to the Oxford Elgin Palliative Care Outreach team included a request by her primary care physician for a palliative physician consultation and end-of-life planning and support.
So, for those of you that haven't actually made a referral to the PCOT team, so essentially our referrals come from several sources. Many of them come from physicians, whether that's the primary care physician, the specialist, the oncologist. Some of the referrals come from the care coordinator or from the visiting nurse. So different ways to refer. There is a formal PCOT referral form that can be used. For physicians in their office that may not have access to that readily, you can use a standard LHIN referral form and just indicate PCOT team, palliative care referral, if that's what you were hoping for. There is a 24/7 PCOT line that you can call, or a fax line. Next slide. And who are our patients? So Kathleen touched on this during her introduction. So just, the surprise question. So I think many of you are familiar with that. So would you be surprised if this patient died in the next year? So clearly we couldn't take all of those patients, but out of those patients, if you have a patient that is frequenting the emerge room frequently, they wish to be cared for at home. So if that's the plan, they're having uncontrolled symptoms, their disease trajectory is in the order of months, and just need help with symptom management. And what are the benefits of having your patients on the PCOT team? So essentially, you get more support. So we're there to support the family physicians and the visiting nurses. Increased communication, and I think Suzanne's going to be talking a little bit more about the huddles and the weekly updates. 24/7 support for the MRP. So essentially during the day, Donna Beth, our manager, is available on that 1-800 number. After hours, it goes directly to the on-call physician. So, for the physicians in the room, if you're doing a house call, you're in the home, you're not quite sure, you need some support or some advice, you can call that 24/7 number. And obviously the same for the visiting nurses. If you needed anything after hours, we're there. And then again, along with the team, we have access to spiritual care and volunteers. So that's an added benefit for your patients. Next slide. And if you're looking for more support, again, for the physicians in the room, we are willing to provide the after-hour support. So we recognize that you can't be available to your patients 24/7. I think some of us had tried that, over the years, and it really doesn't work. So if you're wanting to manage your patient, you'll stay on as MRP during reasonable, business hours. But if you're away on holidays or, outside of usual business hours, we're willing to provide that support. We do ask that if we're not directly involved, that if you're signing out to us, you give us some sort of reasonable notes or a phone call if there's some active issues. We have access to a nurse practitioner. So in Oxford, we have Jane Jennings. And we have to, the nurse practitioner can provide extra support. So if the family doc is remaining on as MRP, she might be able to help with home visits, might be able to be the liaison, between family and the GP. So might allow the GP to remain on as MRP a little bit longer. I have to admit that the resources are somewhat limited. So again, we only have one nurse practitioner in our area. So she's a busy lady. So keep that in mind. And then, for those that want, you can request a consult through the palliative care physicians. We like the family doc to remain on as MRP until the consultation has happened. And again, in situations on a case-by-case basis, if that needs to change, we would appreciate a phone call. So essentially when the palliative physician becomes involved, there's 3 different options. We encourage, option 1, so we encourage the family physician to remain on as MRP. The PCOT physician would do a consultation only, and the family doc would continue to actively manage that patient. So they would be, and we'll talk a little bit more about the MRP role, but they'd be available for home visits as necessary. They would take the calls from the nurses. And then the MRP, the family physician would bill the weekly management fee. The shared care model would be that the family physician and the PCOT physician both see the patient on a regular basis. And that would be a conversation between the 2 physicians to see how we're going to manage that patient. In some cases, the family doc is managing actively, but they may not be comfortable with the pain pump, for instance. So the palliative physician might manage the pain pump and the GP would manage the rest, or they might alternate visits. There's different ways of doing that. And then the third model is a complete transfer of care. And that can happen, if necessary, right from the beginning or partway along the journey if the patient's needs are increasing. Next slide. And again, just the role of the MRP. And again, this is the go-to person for the nurses to call. So you're the person getting the phone calls, available for house calls as needed, working collaboratively, with the team. You would be responsible for the SRK and the EDITH, and again, we're going to talk about this a little bit later, and filling in the death certificate. And again, the palliative physician is available 24/7.
So just back to our story. So she was referred, and the palliative physician and the care coordinator saw her. So the Southwest LHIN care coordinator and visiting nurse also made a joint visit for an initial assessment. At this visit, her care plan was reviewed, and a plan of treatment for CPR was completed. It was determined that nursing would visit her once a week to assess for her symptoms and assess any changes to her medications implemented by her medical team. She was also given an outreach card, which Patti will discuss a little bit later. Mrs. K indicated at that point that it was her wish to die at home when the time came, and her sister-in-law and the rest of her family were supportive of this. So Marlene's going to just touch a little bit on the role of care coordination.
Thanks. So I think Pretty well everyone is aware of the care coordination role in some sense. Of course, for assessing and authorizing the provision of publicly funded home care services, so services such as nursing, physiotherapists, occupational therapists, social workers, dietitians. E-Shift, there's a number of services that can be authorized that are publicly funded. We also collaborate with patients and families to identify and meet their care goal. They have their goals of care set. We try to determine those at the onset of our visits. So goals of care could be to die comfortably at home, to be independent as long as possible, and our role is to help them meet those goals in the best way possible. We also assist patients and families to navigate the healthcare system and to obtain the supports they need. So oftentimes we're putting in referrals to other community agencies and supports. So for example, Mrs. K wanted a referral to Sakura House. We would move forward and do that referral. We could also initiate in any kind of supports that they need. We can refer to assisted living, private pay for homemaking if that's an issue, hospice volunteers as well, which we'll talk a little bit more about in a bit. And we also can do patient advocacy as needed. We also collaborate with the healthcare team to evaluate and facilitate the delivery of the patient's care plan. So a good example of that is our palliative care outreach team, the rounds that we have 3 times a week. As care coordinators, we'll get calls from our providers or from our physicians as well that have concerns, and we'll go back out and reassess. So we're continually kind of reevaluating with the patient their goals and adjusting that care plan to help support them at home. We also, become much more aware of the red flags that might indicate to us that we need to get out there sooner as opposed to waiting for another month or a week. Okay.
So Mrs. K was followed by the palliative care outreach team at home with the support of visiting nursing and other members of the team. During this time, nursing worked with her and her family on the completion of an expected death in the home document, and a symptom response kit was ordered. And Suzanne's just going to go over those pieces.
So the DNRC is already in place, so the next step is to make sure the plan of treatment for CPR is completed, which either the patient and or the substitute decision maker has to complete or sign, and we complete it with them. The expected death in the home forms have to be completed as well. It's important to have that in place in the event of her wish to be home for home pronouncement, and or even if Plan B is hospice, it still needs to be in place in case she stays at home. What we also do when we complete all those forms is we make sure that either the outreach or the most responsible physician is up to date as well to make sure that it's in the place that they know it's a home pronouncement by the nurse. The other one is rounds or joint visits with the outreach team. Rounds are actually every 2 weeks with the nurses. There's actually 3 times a week with the physicians and the care coordinators. It's very, very important to keep up with these. It also informs all the team members, including the physicians that may be on call. It keeps everyone informed of what's best for the patient and to identify if there's any concerns. That way there's less gaps with the plan of care for the patient. Joint visits are very important and are encouraged. That's with the physicians doing home visits with the nurses and or nurse practitioners. We find that the more we do them together, the more the plan of care and the treatment is, let's say there's less gaps. The patient is the focal point of quality of life for as long as they are with us. The other one is the symptom response kit. You never know if there's going to be an unanticipated symptom management that needs attention maybe in the middle of the night. So it's usually what we do is we fax it or connect by phone with the most responsible physician, whether it is the family physician and or the outreach doctor.
So during a home visit with her care coordinator, Mrs. K expressed that she was having difficulty coping with her change in health status, and she was experiencing increasing anxiety and putting her life into perspective. So a referral for spiritual care was suggested by her care coordinator. She agreed this would be helpful. So we just have some points, and Marlene's going to speak a little bit to the role of spiritual care.
So Bill Mayoros is normally our spiritual care provider in Oxford, and Bill couldn't be here with us today, so I'm just going to speak on his behalf. Can you hear me now? Good, sorry. So I'm going to use some of Bill's phrases. Bill firmly believes that spiritual care is an integral part of patient-centered care, as spiritual distress will affect the quality of life of not only the patient, but the family as well. How do we identify when someone's in spiritual distress? And there are some questions we can ask ourselves. Is the patient questioning their self-worth? Is the patient questioning their value to others? Is the patient expressing feelings of emptiness or searching? Is the patient expressing fear of dying or what it's like to die? Is the patient wondering about judgment or divine indifference? So, for example, where is God in all of this? Why has God forsaken me? So Bill's goal when he visits our patients and provides spiritual care is to support the patient, to make them feel valued, and to be able to affirm within themselves that life matters, that their life is important. And that's just a little brief summary of spiritual care.
So one evening, Mrs. K paged her nurse, and she was experiencing increasing shortness of breath. The visiting nurse contacted her by phone, performed a telephone assessment, and through that assessment, subsequently decided to make a visit to her home.
I'm just going to talk a little bit about what the PCOT team does when there's changes in status. So St. Elizabeth and Care Partners have nurses available 24 hours a day, 7 days a week, to provide assistance with pain and symptom management and treatments to our patients. We encourage our patients and family to call the nurse first if there's any change in status. To do this, they would call the office and ask for a nurse to call them back. This usually occurs within a half an hour, depending on how busy the on-call nurse is. We do an assessment over the phone and determine if we need to go see the patient. I usually encourage our nurses to go if there's any unmanaged symptoms or concerns, to complete an assessment prior to calling the physician, and to support the family as well and patient. It's important to remember that the on-call nurse doesn't always see these patients regularly. It's because of this that we developed a recent form that is kept in the front of their binder. On this form, we have information such as diagnosis, primary contact, most responsible physician, the palliative physician, allergies, if any end-of-life paperwork has been completed, end-of-life preference, goals of care, date of birth, health card, and if the symptom response kit is in their home. This is helpful in having all this information when you call the physician. Once again, nursing does their assessment. We call the most responsible physician or the on-call palliative physician, and we update them with our concerns. This is when the physician will then give us some direction for care. A lot of times the patient's goal and our goal as the PCOT team is to avoid possible unnecessary visits to the emergency department. Nursing works closely with the physicians to treat pain and symptoms in their home whenever possible. Our team can do this by ensuring that the symptom response kit is in the home and available. Receiving verbal orders for medication changes or treatments can be initiated from the physician. Health teaching plays a very important aspect in pain and symptom management. We teach the families and caregivers how to administer medications, including sub-Q medications, to provide comfort and symptom relief. If it's the patient's wishes to go to the ER or the physician has directed us to send the patient to the ER, nursing can send a patient status update, and sometimes the physician will call ahead. If it's felt that the patient may require an admission to hospital, the physician can sometimes arrange for direct admission to avoid an ER visit. I'm also going to discuss our outreach card. There's a picture of it on the slide there. So the PCOT team has an outreach card that is given to the patients who are interested and have agreed to become part of our team. On the front of the card, it reminds the patient and family to call the nurse first if there's any pain or other symptoms that they think they may need to go to the emergency room for. Patients, family, and caregivers are asked to call the nursing agency, and the nurse would call them back to determine if nursing needs to make a visit for further assessment prior to calling the physician. On the back of the card, there is the nursing agency, phone number, and patient's name. Most responsible physician, as well as the palliative physician, is documented there. The inside of the card is information in the event that the patient chooses or is advised to go to the emergency department. The information is for the care providers at the hospital. The patient is asked to put the card in their wallet and to provide it to the hospital staff, as it has instructions for the healthcare providers to contact the PCOT team on call after hours, who may be able to provide important information for the patient care. It also allows the healthcare providers to work together with our outreach physicians to develop a plan of care.
So at a previous visit, Mrs. K also expressed an interest in completing an application to hospice as a backup plan in the event that she required more care than her family was able to provide in a home setting, and her family was in support of this plan. It was also suggested by the team that a referral for a hospice volunteer might be of assistance to her and her family. So a referral was made to a hospice volunteer, and she was matched with a trained hospice volunteer that came to her home. The hospice volunteer was able to provide respite support to her and to her family, as well as providing emotional and social support, not only to her, but to also the rest of her family members. So the hospice volunteer also supported her with doing some legacy work in the form of writing some letters to close family members before her passing.
So Sakura House, for those of you who aren't familiar, is a 10-bed residential hospice that feels and functions like a home. It's located in Woodstock. The goals of the house are a provision of a holistic, practical end-of-life care and support, which neither postpones nor hastens death. So something to think about. Imagine if everyone involved in your loved one's palliative care was specialized in palliative care. What a good feeling that would be. And that's the feeling that we get, those of us who are familiar with Sakura House, is confidence in knowing that everybody is truly specialized in that field. Hospice volunteers, Sakura House has hospice volunteers internally. They also have hospice volunteers that come out into the community. And as Sarah said, there are many things that these volunteers can do. They are quite refreshing. My father passed away with ALS, and his volunteer that came out to the house was something that he looked so forward to. They connected very well, and it was something that he appreciated ongoing. Those volunteers can also follow the patients from their home into Sakura House and then provide bereavement support for the families of the patients that have passed. So if you know anybody that's interested in volunteering, certainly there's a need. The bereavement supports, they have bereavement supports in-house at Sakura House as well as in the community. So through Sakura, they send out bereavement cards and letters, and they inform patients and families about the supports that are available for bereavement. They have Caring Circle in Woodstock, Ingersoll, and Tilsonburg to support children, teens, and adults during their bereavement, and they also have one-on-one support. And I believe there may be some brochures back at the back desk. I know there are a number of services as well in the community. I know Woodstock General has some bereavement support strategies as well.
So approximately 2 months later in her journey, it was identified by her visiting nurse at our weekly PCOT rounds that her condition was deteriorating. She was having increasing difficulty getting out of her home for her medical appointments, and her primary care physician asked the outreach physician to make a reassessment visit to her home. So the outreach physician made that visit, and she was started on some sub-Q medications for her shortness of breath and pain control. At that point in time, her PPS was about 30%. Her care coordinator also made a visit and discussed some additional services in the way of increasing her PSW support, as well as increasing nursing supports and the eShift program, which is a fantastic program that Jane is actually just going to speak a little bit about right now.
Thank you, Sarah. So the eShift program is a unique, innovative program where we have PSW, especially trained in palliative, bedside palliative care, supported through technology and iPhone to a directing nurse. So it essentially is a nursing type program such that the PSWs are able to give medications by mouth, injectable medications as well. This all hinges upon a great team of communication, including the visiting nurse, which would be the VON nurse or the St. Elizabeth nurse or the Care Partners nurse or Bayshore. Our program, geographically, we cover from Wyerton to Wingham, Goderich to Stratford, in Oxford County, all the way to Port Burwell, Woodstock, and we do the Waterloo-Wellington LHIN as well. So this is a very unique program supporting palliative patients with end-of-life symptom management. The shifts are usually nights. We do occasionally do a day shift, but most of our shifts are at night. Again, the premise here is that we're providing respite to the family members who are caring for their loved one, but to do that 24 hours a day, they're going to wear out. So the best case scenario for us is when we get a call from the care coordinator early enough in the journey that we could start this support, maybe even just 1 or 2 nights a week. And then as the patient's condition deteriorates, we can, provide up to nightly. We're at a critical shortage in the province for PSWs, and so we are challenged with enough staff to provide it, immediately. So the more that palliative care can be talked about in earlier in the patient's journey and with the family by the care coordinator right at the beginning of the journey, that this is an option, that if they want to stay home, there is support so that they can keep their loved one at home. That doesn't mean that they have to stay home, right till the end, because oftentimes, even when we're involved, there is a choice by the family and the family, the patient, everybody, that they do need to have full service, which would be like Sakura House. So, it's a unique program that we have a few of our PSWs. They can put their hands up. There's a couple of them here, 2 or 3. Oh, one at the back of the room as well. So they've come from various areas to listen to part of this to this day as well. So I think that's it.
Okay. So our patient, Mrs. K, was actually supported at home with the eShift program as well as nursing in PSW for approximately a week, at which point she passed away peacefully, surrounded by her family, as was her wish. So approximately 2 weeks after she passed away, the Hospice and Bereavement Coordinator, on behalf of the Palliative Care Outreach Team, in our area they work at Sakura House, and that's Anne-Marie, they included a sympathy card and sent that off to her family, and included in all that was the bereavement supports that the hospice volunteer had discussed with the family at a previous visit. So her family is currently able to access bereavement supports and still at this point feel well supported in their grieving process. So we were asked just to touch a little bit on some of the barriers and challenges that we have in supporting some patients at home.
So a few of the barriers that sometimes we encounter are patient readiness. Sometimes they go in to see their docs, and their docs are, wanting them to have some support, and I I think sometimes the patients say, yes, I'm going to do that. And then the care coordinator goes out and they say, nope, don't want it. So, that importance of having consent. It's very frustrating and worrisome to family members, too, who are watching mom and dad that maybe need lots of help and won't accept it. Sometimes people don't want a lot of help because they feel it's an invasion of privacy in their home to have multiple caregivers coming into their home, especially as people deteriorate. You're needing to ramp up the supports more, and that can be difficult for people to have strangers coming in and out of their house. We also sometimes have issues with the family being ready or the caregiver being ready to accept support. So an example would be the 85-year-old woman that her spouse is dying and she's still delivering, she's still doing all this personal care and kind of taking care of him. So those are a few of the things that we work with. Sometimes we have to try to convince people most definitely to be open to accepting that service. Rural location can be an issue as well, especially winter weather. That's the biggest factor with the rural. We also sometimes see different processes out of region. So one LHIN will do things very differently than the LHIN beside them, which can create conflict, especially when a patient comes from one LHIN and moves into ours. Human resource limitations, of course. Jane already referred to the PSW shortage, which is certainly a big issue for us. There are also a shortage of hospice volunteers to come out into the home. So once again, if anybody interested in volunteering, there's opportunity. Some areas are becoming concerned about a lack of RNs. And sometimes we have patients come to us with no GPs. So it takes a little bit of fancy footwork, but it gets taken care of. And the last and the biggest piece is lack of communication. So if we're, as care coordinators, especially if we're not hearing from our team or we're not hearing from physicians, we can't help someone if we don't know. So that's the key, I think, for all of us, is that communication piece.
So we just thought we'd include a few take-home points, and Kathleen alluded to these a little bit earlier. Some of the goals of the PCOT program are increasing supports for patients and families, improved communication and collaboration with the healthcare team, more patients dying at their preferred location, at that point, hopefully out of a hospital environment, if that's their wish, increased capacity for palliative care in the community, and prevention of non-essential hospital visits. And again, we've just included the 24-hour outreach line again, as well as the fax number. And we just included a quote there that we thought was a little bit poignant to our palliative care team. So if anybody has any questions.
Sorry. Yes, they are able to administer medications under the direction of an RN. So our program is, the PSW is in the home with an iPhone, then she communicates directly to a registered nurse who verifies the medications that are in the home based on the visiting nurse who was there earlier in the day. So we need an intake assessment from the visiting nurse who lets us know everything that's in the home, all the medications, and if she's doing the preloading of the hydromorph or the morphine. And every day, the visiting nurse is sending us a report if the medication has changed, the dosage has changed. So it's a real collaborative program that takes quite a bit of organizing to get it set up, because unless we have the report from the visiting nurse of exactly what's in the home, the PSW can go in and be at the bedside, but is not able to give any medications. And sometimes it does take a shift or two before we get all the information from the visiting nurses as well. Our directing nurses are quite experienced and open to giving that time and then supporting the PSWs in there, and then the family members are giving the medications during the night for maybe a shift or two. No, this is all the Southwest LHIN. So Care Partners provides the program everywhere except in London, Middlesex, and that's the VON, does the program there. Sorry, I'm moving this. And we also provide it in Waterloo, Wellington. There's a conversation now for it moving to Brampton and other areas like the South or Central LHIN and other areas, but it isn't everywhere in Ontario, no. Okay.
All right, thank you very much.